Now that Indu has dazzled you with the technologies of Health 2.0, I want to show you a technology from Health 0.1. This is an index card. They are on your tables, and modus operandi for getting questions to these smart people is this little toy right here. So what you want to be thinking about doing now as you digest what Indu just said, and as you listen to James and Mark and so forth, pass your cards to the end of the row, and smart little people from the foundation will run around and gather them up, and we will have, that'll be the core of our Q&A session later. But now it's my privilege to introduce James Corbett. Some of you surely know him. At Centura Health, James provides strategic and operational leadership for community health, behavioral health, ethics, and organizational diversity. Before joining Centura, Corbett was Vice President of Community Health and Ethics at Steward Healthcare, where he transformed community benefits programs into strategic population health improvement initiatives, including a community health advocate program that enrolled the uninsured, reduced bad debt, and connected patients. He also established a 24/7 psychiatry call center, which transferred units throughout Massachusetts, and a behavioral health navigator program, which improved emergency room patient flow and integrated behavioral and physical health. Join me in welcoming James Corbett.
Thank you, sir. I've been an executive in 4 different health systems in 4 different states, large multi-state health systems. And I can tell you from firsthand experience, we're in the era of what I'm calling the rise of the healthcare conglomerate, where you have these large mega health systems in multiple states, some of them in other countries. And the question is for us, what does that have to do with making these states the healthiest? And what does it have to do for us in terms of making connections? I think it's going to be important for us to understand the role of these conglomerates and to understand if we're seeking to partner with hospitals, you can't only look at that individual hospital, you have to look at these large systems and their incentives as well. I'm also going to talk to you today about the assigned lives and population health management, often driven by payment reform. And then with this new population health management, I believe the call is for a new notion of population health ethics. So these are the 3 sections I'll speak to you about today. Each section I'll begin with a quote that I think personifies that section. So let's begin. The first one is a quote by Milton Friedman, and it speaks of the notion of for-profit. There's only one social responsibility of business, he indicates, and that is to use its resources and engage in activities designed to increase its profits without deception or fraud. Now, if we take this quote on its face, this becomes a bit of a challenge for for-profit healthcare, because we're not talking about widgets. We're talking about human lives. We're talking about our grandmothers, our parents, and at times ourselves. So what does this have to do with the question of healthcare? But at the same time, we can't give nonprofit hospitals a break, because individuals such as Senator Chuck Grassley highlight that at times nonprofit hospitals are indistinguishable from for-profit hospitals, and that some of the best nonprofit hospitals have de-emphasized their treatment of the low-income, uninsured patients. So as we think of the rise of these large healthcare systems, I think it's important for us to understand both the nonprofit and for-profit backgrounds of these. 6 of the largest 10 hospitals in the country are nonprofit hospitals. Now to be sure, there are lots of benefits of this consolidation. There's opportunities for supply chain savings, there's opportunities for efficiencies, there's opportunities for shared learnings. But the question remains, what do these large systems mean when they're located in different locations? HCA, for instance, has 4 hospitals in England. Hospitals such as London Bridge Hospital and Princess Grace Hospital. So what does that have to do with that local community? How can we draw connections? Well, I think it's important for us to understand the incentives of those local hospitals are important, but we also have to understand the incentives of these larger systems and unpack those. And as we seek to draw partnerships with hospitals, we have to understand what's important for those hospital systems. So today, I hope to pull back the corporate veil, if you will, and speak to you as an executive and help you to understand the inner workings of health systems so you can better appreciate how it is you can partner with those health systems. We're also in a time of great turnover in healthcare. Many of you may not be aware that healthcare CEO turnover led the nation with an 18% turnover rate last year. It shows the amount of tremendous turnover and the tremendous opportunity for those of you in the room who are engaged to get inside of healthcare and help fix this. I think it's an exciting time in healthcare. At the same time, companies such as Press Ganey that do a lot on patient satisfaction, they'll tell you that employee satisfaction is dropping nationwide. And we know there's a strict connection between employee satisfaction and patient satisfaction. A happy employee will go to take that step further and will make sure that patient has a happy experience. So healthcare has a lot of turmoil right now, a lot of change, and a lot of opportunity for partnership. I'm going to turn to the next section, this question of assigned lives in population health management. The comment of assigned lives indicates when you have assigned lives in certain contractual relationships with health systems. Generally, these contractual relationships are budget-based, so the goal is to keep individuals under a certain budget. It inspires us to focus not on the fee-for-service, the churning of procedures, but it inspires us to make sure that those folks in these management contracts can have preventive health, can ensure that their cost of care is at a certain budget, and that their health outcomes are improved. And I believe this is the tremendous opportunity for small nonprofit organizations, foundations, and public health agencies to work together with hospitals on a preventive focus, things that you guys know much better than hospitals ever could, and to work together to improve the health outcomes of patients. The quote we'll begin with in this section is by Mark Twain. Many of you know Mark Twain released the autobiography of Mark Twain 100 years after his death. And I think that this came out and it has some relevance to our conversation today. Mark Twain says, "Consider the wisdom and righteousness of that old-time custom, the paying of the physician by the year. Consider what a safeguard it was for both the physician's livelihood and self-respect, and the family's health. The physician had a regular and assured income, and that was an advantage to him. The family was safe from his invasions when nothing was the matter, and goodness knows that was an advantage to the family." Mark Twain, 100 years ago. In some respects, what Mark Twain was talking about is that kind of fee-for-service on one side, the question of coming and getting procedures done, and the risk contracts on the other. He was saying that payment by the year. That's what we're talking about when we're talking about these budget-based contracts. One bundle of money for the year to care for that individual, usually based on their previous year's expense. And the hospitals can share in that savings if they can keep folks under a certain budget by hitting certain quality metrics. Let's unpack that a little bit further. In some respects, this move, as we hear, from volume to value is a bit of a glide path. It's a stepladder of sorts. On the first step is that fragmented fee-for-service that we talked about that inspires the payment based on a certain procedure. We know what that profit is, and if you get a certain number of procedures, you know how much you can generate. But we're stepping up into this pay-for-performance where we have to hit certain metrics in order to get reimbursed. And those bundle payments in the middle are a significant area for partnership. For instance, on the ortho bundles, if you had a procedure done, you don't just get paid as a system for that one procedure, you now get paid for that episode of care, for the rehab, for all the things associated with that. So clearly that inspires a different type of partnership, a different type of relationship, where you have to work with your rehab folks and can't say, well, I did my procedure, now they get the rehab or not. No, that's no longer good enough. We've got to carry that care across the spectrum, collaborate, partner. If there's environmental, social, or behavioral determinants of health that will help move the dial, we want to know about it. We want to understand it. We want to incorporate that into the care. All the way at the top of the chain, you'll see that ACO full risk model. That is where the real change will happen. That up and downside risk, meaning that you have a certain budget. If you don't hit that budget, you can lose money on that individual's care. If you do hit that budget, you can share in the savings. This budget care is crucial to understand in order to understand how it is you can partner with hospitals. So let's talk about it a bit more. Here's an example, much more complicated than this, but I think it's a good example to make sure that we're talking about the same concept. On the left, this 28-year-old healthy female with a $5,000 projected benchmark, but if cost of care for the year was $3,000. Under that model, $5,000 minus $3,000 means the ACO made $2,000 on her care. This is in this kind of value-based arena. On the right, a 48-year-old obese patient with chronic disease. Projected benchmark was $7,000. didn't do a good enough job that year of keeping the person in the care that he needed, so the cost of care was actually $10,000. In a downside full risk model, the ACO would lose $3,000. As you can see, this is a tremendous opportunity for us to think creatively. What type of cost could we put in place to support that chronic disease patient? How can we reduce their cost of care? How can we partner with nonprofits, public health agencies, and others to think about a healthy community as a way to make all boats rise? We need healthier communities so we're more willing to take risk on populations. That's what's at stake. I think what this calls upon us to do is to think about our population health efforts a little bit differently. In the past, we think about geographic boundaries. We think about the individuals in a certain location. We work with our public health departments in that location for that narrow community that we serve in that location. But what I'm arguing is that with this assigned lives and with different people in different contracts, it defies this notion of geographic boundaries. It requires us to think about these assigned lives and these contracts we're talking about in different geographies, in different counties. It requires us as health system to work with public health departments and others in different ways as we seek to make sure that the folks in these assigned contracts can be kept under a certain budget while we hit their quality metrics and improve their health outcomes. So that is the charge for us as health systems, and that is the partnership, the opportunity for us to make connections, as the moniker for this conference indicates. In some respects, some of the biggest risks we have in this new model is that, this question of narrow notion of medicine on one side and public health on the other. The question is, will health systems dominate and determine what this new notion of population health management means? I think there's a real risk for public health to just that term population health to be reappropriated, focused only on these assigned lives, only on these budget-based care, only on these quality metrics, when we know that this public health has a whole host in the history of Paul Revere, starting in Massachusetts, of learnings that can be shared. And I say it's an incumbent upon us in this room and for public health officials to make sure that we work collaboratively and that we have the learnings on public health, not on the terms only on the health system, but on terms that we can both play a role. States such as New York are moving down the path of pushing social service agencies to be part of this budget-based care. In Boston, when I was there were nascent conversations about whether or not public health departments can start sharing in the risk with hospitals. This is the new arena that we're going to need to work in together, and the tremendous opportunity to focus on preventive health. Why is this so important? Because if you think about how you keep folks under a certain budget, it's going to be important to get them the right care in the right setting at the right time. And we know that by moving down the chain from the academic teaching hospitals to the community hospitals to clinics and to the home, that there's a 20 to 25% reduction in the cost of care. So if we can keep folks in the right setting, that's a good way to keep under a certain budget. And oh, by the way, it's often a better way to provide the care that they want on their terms at a lower cost with better health outcomes. Along the way, it's going to be crucial for us to align. Now, this might not be a popular comment in this room, but I'm not running for office. I believe that we have too many nonprofits. This state has more nonprofits per capita than any other in the country. That makes it harder to align. So how is it that we work together and align these nonprofits so that we can all work in the same direction, all understand the same metrics that we're working on to improve the health of these patients and move in a direction that really allows us to have a chance to make this the healthiest state in the nation? So for the millennials in the room who are out there trying to do good work and often say, I want to start my own nonprofit, I say, please don't. I say, please work with the existing nonprofits. Please help align them and transform these agencies so we can work together with the patient in the center. Some of the things that can happen when you think creatively and you think this way, or you can do things that in the past hospital systems hadn't done. In Boston, I started a program where we were serving healthy meals to low-income, vulnerable patients of different cultures. We knew that the cost of delivering healthy meals for 30 days, married with physical fitness training, diabetes coaches, and others, could reduce the cost of care. So you had a health system, a for-profit health system, willing to pay for that, a different world. And I know some nonprofits in this community are talking about doing that same thing, and I admire that. I think there's an opportunity there. Similarly, another program that I started, and now that we've rolled out at Centura, we have community health advocates, we call them, but community health workers in every hospital now. And what those folks do is they help enroll folks, particularly those limited English proficiency folks. These people live in the communities that they serve. They look like and speak the languages of folks. They help with enrollment, and insurance enrollment is a crucial issue. I was in Massachusetts where the state was able to bring its uninsured up to 98, to its uninsured, it's insured to 98%. But English as a second language community only hit 65%. And we're going down that same path in the state. So I think it's going to be incumbent upon all of us to make sure that we do a better job of enrolling those uninsured, those vulnerable, those hard to reach. And it matters because studies indicate that insurance saves lives. And that if you can have insurance, health insurance, it opens up doors for you. Our three-step program allows folks to do the enrollment insurance. They then get folks into primary care, and then they help them in terms of the care management, trained in expert, motivational interviewing, and other areas. And think about it, when you have those trusted emissaries that took your personal information and that you were willing to talk about insurance with, it opens the doors for all types of conversations. We're going to move to the third section. With this new notion of population health management, I think it inspires a new notion of population health ethics. The quote we'll begin with here is, "When values are strong, rules are unnecessary. When values are weak, rules are insufficient," by Donald Berwick. I think this highlights one of the biggest challenges we encounter, be it from the mortgage crisis, be it high-speed trading. I mean, some of the things that were done in high-speed trading weren't illegal. I'm speaking about those folks who were trading in milliseconds while the rest of us were buying stocks on seconds and minutes. Now, it wasn't illegal by the technical letter of the law, but we could also surely claim that it wasn't what the spirit of the law intended. And I can tell you, with technology, it's hard for the law to keep up. So we're going to need people of goodwill to be in these positions where you can move the dial and ensure that it's not the law that we're following, but it's a higher standard, a standard of morals, a standard value-driven. To highlight some of the challenges in that, I want to highlight what I call a whack-a-mole. And I'm going to use the example of hospital readmissions for this. Many of you know there was a per diem payment. That per diem payment led hospitals to get paid on a daily basis. So what happened when that occurred? All of a sudden, surprisingly, the length of stays in hospitals increased because you're getting paid by a day basis. Why not, right? So longer length of stays. So CMS said, well, that's not what we intended. So let's put a close to that. Well, what happened next? They said, well, come up with this diagnosis-related group payment, where you're going to get paid from that one episode. If you keep them in the hospital for a long time, that's up to you, but you're going to get paid by that one diagnosis-related group payment. What happened then? The length of stays reduced. In fact, they reduced so much that it led to avoidable readmissions. Folks were pushed out perhaps a bit too early. CMS said, well, that's not what we intended, so let's close that loop. They came up with avoidable readmission penalties. And that's where we are now, and the jury's out in terms of what's going to happen. Now, I don't think there are bad players here. I just think that the incentives drive behavior. And what I'm arguing now is we're in a tremendous opportunity with these new incentives around budget-based care and preventive. And let's not have someone come up on this stage in 10 years and say, wait a minute, that didn't work out because of A, B, and C. Let's get in the game together. Let's hold organizations accountable. Let's hold our own organizations accountable, because it's not only the work that we do, we're also consumers of healthcare. So we have both a personal and professional stake in this. One thing that can do from an ethics standpoint to help is this question of the American College of Healthcare Executives Code of Ethics. It highlights that the fundamental objectives of the healthcare management profession are to maintain or enhance the overall quality of life, dignity, and well-being of every individual needing healthcare services, and to create a more equitable, accessible, effective, and efficient healthcare system. So there it is. There's our charge as healthcare executives, and here's your opportunity to hold us accountable to live up to this noble standard. I can tell you, healthcare ethicists often struggle with this new arena where the world has changed around them. So we need a different notion of ethics. Oftentimes, ethics are relegated to ethics committees, very important. But I think that we need to get upstream a little bit more. What are the ethics of payment systems? What are the operational ethics? What are the ethics of healthcare finance? It's a new arena for those who are interested in getting involved. And again, for millennials in the room, if you're interested in this area, it's fertile ground. It's wide open space, and we need more people in this space with a different background and a different understanding of what ethics can mean, a broadening of the notion of ethics. One example, and from the community perspective, of things that ethicists and we all should be looking at is how can we hold large systems accountable? New regulations from the IRS require the Schedule H to be filled out and publicly reported for every hospital in the country. I want to highlight a few of those bolded questions. Let's start with the first one. They're asking, did the hospital conduct a community health needs assessment? I think you all know every 3 years now a hospital has to complete a community health needs assessment. But why is it that it took a regulation to require hospitals to do that? Let's recall that oftentimes these hospitals are non-for-profit hospitals living up to a tax-exempt status. Why it is that the IRS had to say, well, you know, do a needs assessment so you can see what it is you're doing, right? Shame on us. I think we can do a little bit better than that. But along the way, I want to highlight a couple of questions that I think are pertinent to continuing to monitor our opportunities to live up to our greatest aspirations. Question E. Okay, you did a needs assessment now, but did you include a community benefits section in your operational plans? Are you checking the box or are you serious? Right? That's the question there. Question F. Did you adopt a budget for provision of services that address the needs identified in the CHNA? Again, are you looking at the needs and just giving lip service, or are you going to put a budget in place to address those needs? Progressive systems will put a budget in place to address those needs aligned with their population health desires. Focus on the behavioral, social determinants of health, environmental determinants of health. And then last question, bolded, number 7. Did the hospital facility address all the needs identified in the most recently conducted CHNA? Now, there's a lot of needs in those communities, but I argue if you say we didn't answer all of them, tell me which ones you didn't. And if there's a higher than state incidence in that community on that issue, how is it that you didn't do that? Again, these are ways to hold us accountable because we need it. And the most progressive systems are doing it and doing it well. Another area of potential scrutiny can be charity care. We know with Medicaid expansion, the charity care numbers are going to continue to decline, right? Medicaid expansion means more folks are insured. So the question is, tax benefit here, if we were paying taxes, we'd pay X. It used to be with charity care that the numbers are so high, of course we exceeded that. That's starting to even out a little bit as those charity care numbers go down. So we need to make sure that those charity care numbers are aligned with what the tax status is of that hospital. And if indeed there's some benefits that were incurred as a result of a reduction in charity care, let's not put them back in the coffers. Let's translate that into the community in ways that help move the dial. Again, progressive health systems are thinking this way and moving this way, but we can use your partnership. I've talked about some of the risks, I think, under this population health management model that's coming, driven by payment reform, but there's also tremendous opportunities. Some argue one of the largest charges in public health is to address equity, address disparities. And if you think about it for a moment, as we move to this population health management, as we move to figuring out how we can keep folks under a certain budget, it's going to require us to no longer say, well, I'm sorry, the person didn't speak English, so it's not my fault, they didn't follow the care. Or I'm sorry, the person was discharged to a homeless shelter, so he came back to the hospital, it's not my fault. No, it's one budget-based care, folks. Or I'm sorry, the individual was of Asian descent and I didn't know that number 4 was a bad number and they might not show up for the procedure because the procedure room is number 4. We've got to understand people where they are on their terms, on their status, on their culture, and move the dial in that way. And again, the relationships you developed over the years can be crucial to help us to do that. I started with many quotes and I'm going to end with this quote. It's by theologian Howard Thurman and mystic. He argues, don't ask what the world needs, ask what makes you come alive. Because what the world needs is people who have come alive. And I can tell you in healthcare, we need that more than ever. Oftentimes, it's just the person that makes that extra call or makes that extra visit or sit and talk to the patient that extra 5 minutes that will change their behavior. So I ask you today to come alive with me in healthcare. Thank you for your time today.